Hello people, in this video let us look at some hernia Viva questions. So here you are. Length of inguinal canal is, the length of the inguinal canal is 4 centimeter. Next question guys, which was not a boundary of Hasselbalch's triangle? So we want not answer. So tell me the boundary of Hasselbalch triangle. So it's a triangle, so only 3 things. So let us see. Rectus abdominis seems about right. Inguinal ligament, inferior epigastric artery, testicular artery. I have a feeling these three are correct. What do you think guys? Yes. The answer is testicular artery. Look at the Hasselbalch triangle. So here you have the Hasselbalch triangle. So here you have the lateral part of the rectus abdominis muscle forming the medial wall, and here you have some inferior epigastric vessels, and the triangle's bottom part, this is formed by the inguinal ligament. So did we get that right? Inguinal ligament, rectus abdominis, inferior epigastric artery. Very good. Next question guys. Following are true about the external ring except. So here is a negative thing. Following are true about external ring except. It is not a ring. It is a defect in the internal oblique aponeurosis. This is wrong, right? Invagination test is done through external ring. Yes. It transmits spermatic cord. So all these are correct. It is not a ring. It's a triangle in shape, isn't it? So look at this image here. So you can see here, this is the external ring. It is not a ring. It's more like a triangle. You can see it is a part of the external oblique, not of the internal oblique. And then it is helping the spermatic cord go through. Yes, all this is correct. So the correct answer here will be, it's a defect in internal oblique aponeurosis is wrong. Shall we go to the next question people? About deep inguinal ring, which of the following is true? They are asking for true statement guys. About what? About the deep inguinal ring. Okay. So let's look at this deep inguinal ring. So what are they talking about here? This one, the deep inguinal ring. They are asking for you, the true statement. The answer here is the defect in the transversalis fascia or the fascia transversalis. Look at this. So here you have the deep ring, and here you have the, what exactly is it coming from? Fascia transversalis. Okay. Then. Okay, next question guys. Look at this. Following are true for deep inguinal ring except. Same deep inguinal ring only they are asking about, and here it is an except question. So let's mark it in red. So look at all the options and come to a conclusion. So deep inguinal ring again. So here it is there, and they are asking about it. It is a defect in transversalis fascia. We know that this is correct. Then indirect hernia sac comes out lateral to deep ring. What is that? I didn't focus. Pantaloon hernia can be on both sides of deep ring. It is closed at the end of hernia repair to prevent recurrence. Then how will the spermatic cord come out? Why do I feel this is wrong? It is not closed. You will not close the deep inguinal ring. Remember in Lichtenstein repair and all etc. what you will do? You will put the mesh like this, and then the mesh you will cut here, and then you will cross these two parts so that the spermatic cord can go through. You never close the ring, isn't it? So indirect hernia sac comes out lateral to the deep ring. So if this is the deep ring and this is lateral, so the sac comes out lateral to the deep ring, is it? What are they saying? Then guys, focus here. What's the next option that they have given here? Pantaloon hernia can be on both sides of deep ring. Pantaloon is kind of a mixed hernia where you have direct and indirect component, isn't it? So it can be on both sides of deep rings. Sounds like a correct statement. So you got your answer. Shall we move on to the next question guys? You're done with 5 questions. Let's move on to the 6th one. The ideal surgical treatment for sliding inguinal hernia will be. So what is sliding inguinal hernia? We have seen that it can occur with cecum and all, right? So first of all, understand what sliding inguinal hernia is. So first understand sliding inguinal hernia guys. So here's the photo for sliding hernia. So it is also called as hernia in glissade, and it's an acquired hernia. It's always an acquired hernia. So it occurs as a result of the slipping of posterior peritoneum along with the retroperitoneal viscus. As a result, what will happen? The cecum on the right side and the sigmoid colon on the left side form the posterior wall of the sac. So what happens is if this hernia occurs on the right side, the cecum becomes the posterior wall, and if it occurs on the left side, the sigmoid colon becomes the posterior wall of the So they form the posterior wall of the sac. But if appendix and cecum both are the contents of the hernial sac, it's not a sliding hernia. What else is there here? It's always occurs in males, okay, the sliding hernia. Then it is left-sided is more common. In this photo, they are showing the urinary bladder, which is there, a part of the urinary bladder is here. And in this photo, they are showing you the sliding hernia, they say. Basically, this question is about the treatment for sliding inguinal hernias. Just look at this key points about sliding hernia. It's almost always acquired. It's in males. It occurs in long-standing hernias. It's always irreducible. Always colon or urinary bladder forms the wall of the sac, which we told you here. The colon or the urinary bladder. Here they're showing you urinary bladder. Here they're showing you colon. It requires a repair. Always technical difficulties are encountered by junior surgeons while operating on these patients. Okay, did you get the answer to your question? Let's look at the treatment part from the textbook. Truss is absolutely contraindicated. What is truss? Truss is more like an engineering term, which they are saying is like something like, a bridge kind of a thing, okay? Then, what else are they saying for the treatment of this sliding hernia? So, you should not twist the sac. Once the sac is open, the sac should not be twisted, okay? So they'll remove the sac and they'll repair the hernia. The purse string suture is applied, they're saying. And in the elderly patient, orchidectomy is advised to give permanent cure. So here, what is the answer? This ideal surgical treatment for sliding inguinal hernia will be. So, were you able to reach the answer, guys? Okay, Lichtenstein repair is the correct answer. Now, let's move on. Following are the contents of spermatic cord except. Guys, we have moved on to the next question. Have you? So, following are the contents of spermatic cord except. So, let's look at the contents of spermatic cord. Okay, so here you have the transfer section through the spermatic cord. What are the contents? Can you tell me? There is some, let's look at the red ones here. Artery to ductus deferens with sympathetic plexus around it. Okay. Here you have the testicular artery. What exactly is this one? Ductus deferens. Then you have some lymph. Then you have some nerve here in the yellow, genitofemoral nerves branch. Then here you have some artery to cremaster. This is kind of outside, isn't it? And then you have the cremastric fascia and the ilioinguinal nerve, which is outside. So let's leave all that. Then what are these in the blue? These are veins of Pampiniform plexus. Okay, guys, are you focusing? There are some blue things, there are some red things, and there are some yellow nerves. Here you have some lymph. Then you have the ductus deferens. Okay, outside it, what is there? Let's not bother much. Now let us see if we can answer the question. Following are the contents of spermatic cord except. They want an except. Vas deferens, yes, it's there. Testicular artery. Did you see a testicular artery here? Go back here. Yes, we saw. Good. So testicular artery is there. Then genital branch of genitofemoral nerve, yes. Ilioinguinal nerve, we saw it is actually outside. So is this the answer? Let's look at the solution. Yes, this is the answer. That's correct. So let's move on to the next question, guys. 8th one here. How's it going, people? About sliding inguinal hernia, following are true except about, see, we'll give you a break for every 5 MCQs, okay. So just focus here. We are looking at the, how manyth one? Why is this photo so huge? Yeah. So basically we are looking at the 8th one. About sliding inguinal hernia, following are true except. See, already you read about sliding inguinal hernia. So you should be able to answer this. Take a break and see if you can answer it, okay. So this is what I think the answer is. The hernial sac should be twisted is not correct because you should not twist it in sliding inguinal hernia. They have told that. So 8th one, what is the answer to the 8th one? C. Very good. Now let us look at the 9th one. Richter hernia refers to. Richter hernia refers to, you know this one. See, Richter hernia, only part of the circumference of the bowel is strangulated. So you may overlook the gangrene if you don't look carefully. So in these people, there will be no obstruction, right? Though there will be features of obstruction, there will be no obstruction. In fact, this person will have diarrhea with blood and stools. Now let's go to the question and see if we can answer. Richter hernia refers to. Come on, answer this. Without even breaking head too much about all the other options, we can choose this one. Only a part of the circumference of the intestine is caught in the hernial sac, isn't it? Reaching the 10th one. Immediate structure anterior to direct hernial sac is. So you have a direct, this person standing here, he has a direct hernia. So there's a hernial sac. Immediate structure which is anterior to the direct hernial sac. There's a sac in front of it. Exactly what is there if they ask you what is there. Okay, so think about it. So the answer is transversalis fascia, the textbook says. So let us try to understand this. See, this is inguinal canal, but don't think about that. So here you have the direct hernia. So what is just in front of it, they are asking, looks like the answer is fascia transversalis. Okay. Okay, let's move on to the next question. Okay, anyways, as you have finished 10 questions, you can take a small break and enjoy. Take a deep breath. Let's continue with the 11th one. Femoral hernia has following features except. The answer is already marked, but look at the correct ones. It is common in women. It is below and lateral to pubic tubercle. It's known for strangulation. Femoral hernia, you have read this. So you remember that the femoral hernia is more prone to strangulation. It is lateral. It's lateral and below the pubic tubercle, which is shown here. So it is below and lateral to the pubic tubercle. Are you able to see, guys? You want a better color? So it is below and lateral to pubic tubercle, and it is more prone to strangulation. All those are correct. What else? It's more common in women. It's also correct, especially multiparous, isn't it? Yes. Now let's go to the next question. Diagnostic feature of a saphana varix is. So you want the diagnostic features. They're talking, the main topic here is the saphana varix. The saphana varix diagnostic feature. Come on, can you answer this? Saphana varix is nothing but the dilation of the saphenous vein at its junction with the femoral vein in the groin. Look at this. So from below, you have the dorsal venous arch. Then here you have the great saphenous vein, isn't it? Which is going here behind the knee and then coming up, and it is joining with the drains into the femoral vein. You also have a short saphenous vein, which we will explain. This is the great saphenous vein, is it? And then here you have the femoral vein. So remember, the great saphenous vein is actually medial. Okay, it is medial. The small saphenous vein will be lateral. Okay, so what are they asking here? The diagnostic feature of saphana varix is, it is transilluminant, soft and reducible, below the pubic tubercle, disappears on elevation of leg. Why do I want to say it disappears on elevation of leg? That is the whole thing they taught us in varicose veins, right? Basically, it disappears on elevation of leg, the pooling of the blood. Which of the following hernia is called Litte's hernia? Okay, let us see this. The hernia, let's look at the answer. First of all, what is Litte's hernia, guys? Look at this. So, Litte's hernia, what are you seeing here? Meckel diverticulum? Yes. So, Litte's hernia is referred to as a hernia containing Meckel's diverticulum. When the diverticulum gets infected, such hernias are called as inflamed hernias. Again, in these cases, there can be strangulation without obstruction, okay, like Litte's hernia, Richter hernia, right? Those are cases where there can be strangulation without obstruction. What and all are the three things where you can have strangulation without obstruction? Omentocele, Richter hernia, and Litte's hernia. Okay, that just went away somewhere else. So now just focus here. What is the question here? The question here is, which of the following hernia is called Litte's hernia? Hernia containing Meckel's diverticulum could be the answer. Let's look at the answer. Very good. Let's move on to 14th one. Which one of the following is the most important step in preventing recurrence of hernia? So here they're talking about prevention of recurrence of hernia. So important step, they're asking most important step. So let us see. So you want to prevent the recurrence. So let us read this. The answer is high ligation of the sac. So high ligation of the sac is the most important step in preventing recurrence of hernia. High ligation of the sac is the answer. Let's move on to the 15th question. Following are true for strangulated inguinal hernia except. It's an except question, guys. So here you go. Strangulated inguinal hernia will be irreducible. Yes, I think so. It will be tense, tender. See, it will be tender because it's strangulated. He will have pain, isn't it? It will be tense. I have a feeling, yes. I have a feeling impulse of cough cannot be present because it is strangulated. I'm thinking it is obstructed. Adhesions will be there. What do you think, guys? Yes. So the answer is impulse on cough is it will be absent for strangulated inguinal hernia. Okay. Next, 16th question we have to go. Okay, so time to take a break. You have finished 5 more. So now let's go to the 16th one. Following are true for anatomy of the femoral canal except. Femoral canal anatomy. It's an except question, guys. Focus, and it's about the femoral canal. So basically, what do you know about it? So here is the femoral ring, and here you have the femoral canal, right? Is that the femoral canal? So what and all do you have in that? You have the lymph node of Cloquet, you have a vein, you have an artery, and you have a nerve, right? So that is the femoral canal. So it contains lymph node of Cloquet is correct. Then femoral canal is below and lateral to pubic tubercle. I want to say that is true because that's how a femoral hernia presents. Then it extends from femoral ring to saphenous ring, is it? Sounds about right. Femoral canal is outermost compartment of femoral sheath. So this we'll have to check. Let's check this. See, what is the femoral canal? See, this is the ring. I'm thinking that femoral canal they're showing here. Where is the sheath? See, here you have the femoral sheath which is shown in the green, and inside it you have the femoral canal. So the sheath is enclosing the canal. Is there anything else that we're missing here? Because here the question says femoral canal is outermost compartment of the femoral sheath. Somehow this doesn't go with us. Okay, let's go to the 17th one. In obstructed femoral hernia at surgery, which of the following steps should not be done? Not. Obstructed femoral hernia. We're talking about an obstructed femoral hernia. Which step should not be done? Okay, look at all these options. So you will close the ring by Proline suture. Abnormal obturator artery should be looked for. This we have already seen that there is an artery anastomosis. Right, urinary bladder may be in danger. Sounds about okay, right? Let's see. Let's take all these. Best done with low approach through incision directly over the swelling. What we have understood is there is something like Henry's approach which they like. See, there's a McEvedy high approach. There's a Lockwood low approach. So many approaches are there. Okay. But what they're telling about the low approach is that they do it only if it is an uncomplicated case, and it is very difficult to manage a gangrenous loop of bowel with this approach. So forget this low one, okay? What they want to do according to this MCQ is that best done with low approach through incision directly over the swelling is wrong, okay? It should not be done. Let's go to the 18th question, guys. Following hernias are known for high chances of strangulation, except we already told you this, okay? Femoral hernia is prone to strangulation. Right, femoral hernia is prone to strangulation. So the question is all about strangulation. So femoral hernia strangulation can be there. Obturator hernia also I have a feeling because it's coming out of a small space. So I want to select this. What is Spigelian hernia? Kind of coming out from between these two spaces. So I have a feeling it can get strangulated. Yes, why not? But when it comes to direct, and it's coming out of the abdominal wall directly, I have a feeling strangulation, the chances are low. What do you say, guys? So let's go with, for 18, let us go with D as the answer. Okay, let's check. Yes, that's correct. So now let's move on to 19. In which condition femoral hernia occurs behind the femoral vessels? Oh, this is slightly complex. We don't know this one, right? Let's look at the answer directly. Congenital dislocation of the hip. If there is congenital dislocation of the hip, the femoral hernia occurs behind the femoral vessels in congenital dislocation of the hip. In cases of epigastric hernia, all are true except. What is this epigastric hernia? All are true. All are true except. So you have to look for the negative statement, guys. Let's look at epigastric hernia. The epigastric hernia is here, see. Are you able to see, guys? So basically you have umbilical, para-umbilical, right, around it, and then you have the epigastric. Yeah, so what is epigastric hernia? And what is the question they are asking you? Let's check. Wait. So basically it is also called as the fatty hernia of the linea alba. Okay, the hernia occurs through the epigastrium, through the linea alba, which extends between the xiphoid process and the umbilicus, which you have already seen. So they have shown you here in the center you have the linea alba. So somewhere through it is coming, is it? This epigastric hernia. Please go here. Yeah. So look at the peculiarities of epigastric hernia. It is common in muscular men. Hernial sac is uncommon. Hollow viscus in the sac is rare. Impulse on cough is rare. Reducibility is rare. Tenderness is an important feature. Tenderness is an important feature. It's common in men. Let's see here. So with all this information, we can answer this. It is tender is correct. It is tender. Sac is uncommon also we saw. Impulse on cough is, what is this? Impulse on cough. Impulse on cough is rare, so it doesn't happen. Impulse on cough is common is wrong. So it doesn't have impulse on cough. It's more common in men is correct. Okay. So, peculiarities of epigastric hernia is that it is common in muscular men. The hernial sac is uncommon. The hollow viscous in the sac is rare. Impulse on cough is rare. Reducibility is rare. Tenderness is present. Okay. So, what and all are not there? What and all will not be there usually? Impulse on cough will not be there. Reducibility will not be there. Hollow viscous in the sac also won't be there or rare. That's what they mean. Okay. Just 5 more guys. Let's finish off. Okay. Spigelian hernia is an example for, come on, see the answer. It's an example for interstitial, sorry, it's an example for interstitial hernia. What is a Spigelian hernia? You saw, right? Did you already forget what Spigelian hernia is? So that's why they're saying it's an interstitial. Okay. Next. In Spigelian hernia, swelling is seen where? I want to say, it is below and lateral to umbilicus. Below is correct. So, below and lateral to umbilicus, is it? Lateral is also very perfectly, we can say it lateral and below. Yes. Makes sense, right? This belt, Spigelian belt itself is below and lateral, below the umbilicus. Okay. Then 23. Differential diagnosis of lumbar hernia include the following except. There's a lumbar hernia, is it? Except question. So, differential diagnosis they are asking for this. So, the answer is meningocele. Okay. So, you can think of lumbar hernia to be a lipoma or a cold abscess or a hematoma. So, just touch there behind lumbar hernia, lipoma, cold abscess, hematoma, but it won't be a meningocele. Okay. Following are true for obturator hernia except. So, we are looking at this obturator hernia guys. So, basically this will not be covered by pectineus muscle. Okay. So, these and all are correct. Pain will radiate to the knee, cannot be felt on vaginal examination. Patient keep their legs semi-flexed in this case. Okay. Last question. The most common presentation of obturator hernia is, again about obturator hernia they are asking, this is a true statement they want. The answer is, the most common presentation is an intestinal obstruction. The most common presentation of obturator hernia. Interesting, right? It's an intestinal obstruction. Strange. Okay.